Hello, students, and welcome to Chapter 12 in Neurobiology. This is on the neurobiology of psychological disorders. Now, there will be other chapters where we talk a little bit more about some disorders as well, and this chapter really focuses on just a couple, but I think you'll get the sense from, especially even just the first few, of how much and how little we know about the neurobiology of each of these psychological disorders, and some of the common things, whether it's brain areas, neurotransmitters, and things like that that are have specific differences with each different type of disorder. So let's get into that. So in abnormal psychology is kind of the field or the area in a general psych book. Abnormal psych is the one on disorders. It's the kind of what we've named that area of the field. And so an abnormal psych book will go into a lot more detail on the cognitive processes of disorders, the socio-emotional processes of disorders, as well as a little bit in the biological processes of disorders. Since this is a neurobiology class, we're going to really focus on those biological processes. There might be a little tiny bit of cognitive or socio-emotional mixed in there, but it's pretty much exclusively focused on biological. So with that, that is our focus. But with that being said, before we go, this kind of graph, Venn diagram, that's what these are called. This Venn diagram really goes to show that all of these are happening at the same time. For any given disorder, there are contributions from all of these pieces. And you'll see that all of these disorders in the book have like a range of this is how heritable it is, this is how biological it is. And that's the case. There's socio-emotional pieces, there's cognitive pieces, and you'll see some of that interaction today, but we focus a lot on this biological piece. All right, so some of the things that we will focus on each of these disorders: genetics, or are there genetics, how much of the genetics, brain structure. Some of these are really tied to specific structures or areas in the brain, brain function, or how does the brain network itself, which areas are networked together stronger or weaker in different disorders, and then brain chemistry. So all of those are really intertwined. So the neurotransmitters being sent and received, having too much or too little of neurotransmitters, as well as brain function and brain structure. Again, all of these are happening at the same time. They're all connected, totally interlinked together. So with this, the biopsychosocial approach is the combination approach of all of these. So a little more detail. So biological, we just talked about that, but psychological, responses to stress or patterns of thinking, cognitive aspects, sociocultural, cultural expectations, definitions of normality. So you've probably learned this in other courses about disorders specifically. How do we define disorders? And essentially, it has to be outside of cultural expectations. So there are grief disorders, but being very seriously grieved by the loss of a spouse or significant other, for even a couple months at a time and having a really hard time doing things for yourself in that immediate aftermath, that's pretty culturally appropriate here in the US. Other cultures have different mourning periods that are kind of culturally expected. So when we're talking about abnormal psychology, these are things that are outside of what is perceived of as the average or standard culturally in that area. All right, another big thing that we will get to with essentially all of these disorders. Some it has a bigger impact, some it has a lesser impact, but the diathesis stress model, and I usually actually call it diathesis stress model, so I may mess up my words there. So diathesis stress model essentially is saying there are risk factors, there are vulnerabilities, there are predispositions. So that's the diathesis piece. It's those vulnerabilities, it's predispositions that are then susceptible to additional stresses. So genetic susceptibilities, like you're X percent as likely to develop depression. But having additional stress gives you more likelihood that you will actually develop depression. So this is relevant in both schizophrenia, depression, anxiety, eating disorders, PTSD. All of these are made worse by stress, or more likely by stress as well. So this graph here that was on the other page, it's just blown up here. So this could be, you could think of this as any given person's predisposition to that disorder. So let's say it's depression. So this is that person A's predisposition to depression. So they have this predisposition, and then they had these stresses. This is how much stress they had. They still are falling below this threshold of developing depression because their predisposition to depression is lower than, let's say, A, B, C, D. Person D over here has a higher predisposition. So just genetically, they're a little more likely to get depression, and they have that same, these might not actually be the same, but essentially, let's pretend these are the same amounts of stress. Because they already have that predisposition, they are crossing that threshold. They are now going to be getting depression. Versus this person over here, they had very little stress, but they have that high predisposition. So they have genetically very high likelihood of suffering from depression, but they just don't have as much stress in their life, so they are not above that threshold. Another piece here is this resource. Another word for resource, you think of the predisposition or the diathesis as the risk factors or the vulnerabilities or those predispositions. A resource is a protective factor. So something that decreases your likelihood of getting that disorder. So as a good example for depression would be close friends, close relationships is a good protective factor. Eating and working out and being healthy in general is a protective factor. So that's here. So you can see the threshold is jumped up because all of these people have some of those protective factors. And that's really the main idea behind the diathesis stress model, is that you have a predisposition for a lot of these. Again, for any individual, it might be, let's say this is 5%, this is maybe a 20% chance of developing the disorder, but stress is another component there. Sometimes these are epigenetic changes, and sometimes these are just triggering events because of the stress. So, again, diathesis is that vulnerability, that predisposition. Stress are those things in the environment, and then you might be more likely to develop that disorder. So the first one that your book dives into is one that a lot of people are interested in, is schizophrenia. So let's learn a little bit about schizophrenia. So schizophrenia includes all of these symptoms over here, positive and negative symptoms. When you think of positive and negative in this context, this is not like this is a good symptom or this is a bad symptom. These are all bad symptoms. These are all things that people don't enjoy dealing with. The positive is things that are added to an individual versus negative are things that are like taken away. So it's like math, addition, subtraction. So positive, added symptoms, negative, taken away. And there's also a third category, disorganized symptoms. So disorganized symptoms are things like disorganized speech and behavior. With this, it's also related to cognitive difficulties like the just difficulty thinking, attention, memory problems, things like that. So schizophrenia in and of itself is characterized by major disturbances in thought, cognition, perception, emotion, and behavior. So some of the positive symptoms that we see are things like delusions or hallucinations, and refer back to your book. In most of these, especially in this behavioral health class, I'm guessing that you've gone over in previous classes more of the details of these disorders. So we'll give kind of a quick reminder and then dive straight into the biology for all of them. So positive symptoms are like things added to the person with schizophrenia. So delusions, hallucinations. Negative are things taken away from that person. So like flattened affect, they seem to maybe have no emotion, not really responding to things, maybe not speaking, are some examples. So these are two good videos linked here. I definitely recommend watching this one. This is a really good overall TED Talk about someone's experience with schizophrenia and their challenges with getting treatment for it. But I wanted to show this pretty quick one of, and basically this artist's depiction of what schizophrenia is like to them.
Look out the window. I'm trying to show people the experience of schizophrenia with a lot of people is that everything is alive, and you can't choose that perception. It's an artistic depiction of how it feels both emotionally and kind of overwhelmingly. I was in my second year of university, and I remember I'd be in class, and I was doing like art school, and I would have to leave the class, and I didn't know why, but I just started going underneath like the staircases at the end of the building and just hiding. And I remember in those moments, it wasn't voices yet, but it was intrusive, like if intrusive thoughts had life to them. I started hearing just little like laughter here and there, like little shrieks and little things. And I just kind of thought to myself, okay, well, like this is weird. I feel like I'm like, is this tripping? Am I tripping? And I got really confused. I dropped out of university because I couldn't deal with it anymore. I remember it ended up in me being homeless and traveling around my province in Canada. It's New Brunswick. My art with hallucinations started when I was homeless, because I used to graffiti and I used to kind of like have permanent markers with me everywhere. Schizophrenia feels like there's always a ghost around you. You always feel like there's something like haunting you or around you, and you see things, and it's such a weird experience that the only way I could express myself was by starting to draw the faces.
Sometimes when I'm not hallucinating, I'll draw them more neatly, but right now I'm hallucinating, so I would love for you guys to see the spirits coming out of my hand.
It got to a point where I was drawing the faces, and I'd look at them on the wall, the drawing that I did, and I'd start talking to it. And so I started building a relationship with this thing. I started to draw them more and more when I was getting out of the psych unit for the first time I was hospitalized, because there was something about it that was so comforting, and I felt like I wasn't as alone as I used to feel. When I'm making an art piece, I feel like kind of ethereal, like I'm making it and I feel like I'm doing something for myself, for other people, and it feels like a service.
Do you see them like as people, or are they stylized, or are they... You have to understand that schizophrenia is so much more complicated and multidimensional in how it works.
Hurt everyone you love. Hurt them. Hurt them.
We all have intrusive thoughts, okay? But just because I'm schizophrenic, it doesn't mean that I automatically have voices that are like, kill, kill, kill. It doesn't work like that.
There's so many people that I met, especially through TikTok, who have schizophrenia, who are practicing lawyers, who are doctors, who are nurses. It's a spectrum, and there's such a thing as high-functioning schizophrenia. If you can watch my experiences and understand that, you know, all these things that people think about schizophrenia are mostly wrong, then you start to learn something new, and then it makes the world a better place because people are connecting again.
So, good example of one person's experience with that. Again, any person with schizophrenia might not have any of those positive symptoms like delusions and hallucinations. Also, auditory hallucinations are the most common. Also, just because someone has hallucinations doesn't necessarily mean it's schizophrenia. High fevers can cause hallucinations, but again, auditory hallucinations are the most common. Negative symptoms are also very debilitating for people as well, can make relationships very hard. So hopefully that gives you a good sense of like the struggle that people with any of these disorders are carrying around with them and how hard it would be to deal with that. Now let's talk about what the brain is doing, or what is the brain doing to lead to these kinds of outcomes. And so one thing that we see in people with schizophrenia is that they have enlarged ventricles in the brain. And so here are some pictures of the ventricles in someone who has schizophrenia's brain versus someone who doesn't. Essentially, this means that some of those areas, they're in the middle of the brain, are smaller. So they've got a little less gray matter, a little less white matter. You've got a little thinner cortex, specifically a smaller hippocampus, amygdala, and thalamus. And then also in some of the frontal and temporal lobes, you've got a little bit thinner cortex there. And what this leads to is that there's just a little bit fewer neurons to do some of the processes that the rest of the brain would generally do before the disease or in someone without the disease. So another thing that we see is that the hippocampus is very hyperactive. And so it seems like there are dysregulated dopamine pathways. And the problem with that is that dopamine does a lot in the brain. It doesn't only do, it does a lot of activation across the whole brain. And so with this, it in someone with schizophrenia, one of the main things that seems to be affecting is interpreting how important some input is. So maybe there's a firing in the neurons, and that the brain and a person who's suffering from schizophrenia is sending more dopamine, saying this is an important input, whereas in someone else, that input might have just died. It wasn't actually important. It wasn't actually an input. They might get a slight sensory input and then be interpreted as bigger than it was, leading to something like an auditory hallucination, for example. And so it's difficult to determine for the brain if the input is real or as important as it should be. So that's part of it. So there is dysregulation in those dopamine pathways. But again, dopamine does a lot of things in the brain. So it is interconnected. So with this, the negative symptoms, interestingly, are correlated with reduced dopamine activity in the frontal cortex. So over here towards the front of the brain, so reduced activity there, and then positive symptoms, and so that's for the negative symptoms. So like pulling away, flat affect, and then positive symptoms are correlated with closer here to the midbrain, having more hyperactivity in the dopamine there. So other neurotransmitters, serotonin, glutamate, these play a role as well. And it is very complex. It's a lot of systems in the brain that are being affected by these areas and those neurotransmitters. And diathesis stress plays a really big role here. There are things that we've seen are pretty common for people with schizophrenia. So complications giving birth, maternal stress, even before being born, exposure to influenza during the first trimester of pregnancy. All of these seem to be additional stresses that make it more likely that someone will develop schizophrenia. Other things that we see is substance abuse disorder can be both a cause and consequence of schizophrenia. So it can be a stressor that leads it to be more likely to develop schizophrenia. And it's also fairly common for someone with schizophrenia to self-medicate and develop substance abuse disorder as well. So hallucinogens and psychedelics are actually a risk factor to create schizophrenia. So again, diathesis stress model, you've got that genetic propensity for schizophrenia, then you use a psychedelic or hallucinogen, including even marijuana, LSD, psilocybin, it can then risk a psychotic episode and increase the risk of developing schizophrenia. And a lot of people don't know because the first time that one, if you know family members have it, that's really the only way you would know because usually it's diagnosed in early adulthood. So that person talked about how they were in college and they started having symptoms. That's pretty common for people who develop schizophrenia to start to have those kinds of symptoms in their early adulthood. So for treatment, psychological and family therapy interventions are very helpful. So reducing stresses overall with support networks, having therapy like cognitive behavioral therapy, giving resources and ways to deal with stress and emotions. Medications can be helpful. So second generation or atypical antipsychotics are the things being prescribed now. So these are things like clozapine, risperidone. I'm not even sure how to say this one. I don't know that I've actually ever heard it said. I think I might have only ever read it. So this one. The thing with this is that these affect both dopamine and serotonin receptors, and they seem to be better for both positive and negative symptoms. So there are certain other drugs that were used in the past that were antipsychotic drugs that really only focused on the positive symptoms, but doing things for both the positive and negative symptoms is obviously better, working on all of those symptoms. So hopefully with this example, you can see a little detail of how complex the system in the brain is. So we've got the ventricles, a little bit less matter in some areas of the brain compared to average, and we see hyperactivity or less activity in different pieces of the brain. And those networks all together are pieces that help explain some of the symptoms people have. Now we'll dive into a lot more depth too on a couple mood disorders, and that is a really good one to see some of these common features throughout developing disorders and the biological connections. So again, we won't focus on the diagnosis of these disorders. We'll touch a little on treatment though, but the main thing we'll focus on is a little reminder of what these disorders are, and then focus on the neurobiology behind them. So mood disorders are those that have severe disturbance in mood, emotion. So we're talking things like mania, depression. There are also cognitive and behavioral and even physical symptoms. And oftentimes these lead to interpersonal difficulties as well. There's two categories in the DSM-5 right now. So one is depressive disorders and the other is bipolar and related disorders. So thinking about depression, we'll spend a lot of time on major depressive disorder because it's one of the most common disorders in humans. And then also it is a really good example, kind of like schizophrenia, a few of these things that we've talked about that really dive in, and we know a lot about it because we've done so much research on it, on the neurobiology. Whereas some, it's a little less clear exactly the neurobiology behind them. So, major depressive disorder is characterized by that sadness, that loss of pleasure in usual activities. Oftentimes, people just don't want to do things, and any of the combination of these symptoms. Again, feel free to remind yourself this is just a little bit of a reminder of major depressive disorder. It's probably something you probably have members of your family that have it, or people in your life, or even you yourself. Again, this is one of the most common disorders. So, bipolar disorder, on the other hand, is changing between stages of depression and mania. So, mania episodes can often last for just about a week, or at least a week, or a couple days, like 4 days, and then go back to a state of depression, which is usually what is for bipolar disorder. The person is generally in depression most of the time. So it can be hard to see, is this depression? Is this bipolar disorder? Because from the outside and some of the symptoms, oftentimes it looks a lot like depression. So there's a good video here that goes over some of these causes. I definitely recommend watching that after you've gone through the lecture this week. We won't watch it like in class right now. So in episodes of mania, you get extreme elation or agitation. You might be cheerful or euphoric, have a lot of talkativeness, be very interested in doing a lot of things, maybe very irritable, very reckless. These are all very common. So bipolar 1 requires at least one manic episode, and that manic episode lasts nearly all day, every day for at least 1 week. So they usually, humans, even if they're in a state of mania, we can't maintain that level of alertness and intensity for a ton of time. So it will drop back down to a depression eventually. Bipolar 2 is less severe mania, but that's happening for at least 4 days. So depending on what it is and the characterization, there's also rapid cycling bipolar. So oftentimes people will make a really terrible comment about someone, say, oh, they're really bipolar, meaning that their personality kind of changes. They're really up or down, or they're friendly or not friendly. And one, that's a really terrible thing to say about someone, uh, to use bipolar disorder as like a pejorative term to say something bad about someone. How do you think your friend who might be standing next to you with bipolar disorder might take that, for example? If you're saying, hey, this person's being a jerk, and then sometimes they're being nice, they're bipolar. Someone with bipolar probably is not going to look too kindly on that kind of comment. So just, you probably are aware of that in this class. You're probably at that point, but it's something I like to try and remind people, as well as that's really not what bipolar looks like. So bipolar, even rapid cycling bipolar, is 4 or more episodes of mania or depression a year. So months and months of depression, then a period of mania, months and months of depression, period of mania, and switching 4 or more times a year. It's not switching 4 or more times a day, 4 or more times a week, 4 or more times a month. It's going to be kind of month-long sessions of depression. So just to make sure that's a little bit clear before we look at what the brain is doing specifically in depression. So we kind of talked about mood disorders, we talked about major depressive disorder and then bipolar, and now we're going to focus on the neurology of major depression. So brain activity, we see decreased activity overall. So overall the brain, so depressed. So just like alcohol is a depressant, it makes all of the neurons work a little bit slower. We see kind of that same thing with depression. It's not the same as alcohol, but it's a depressant, so similar in some ways with the neural activity. But a main area that we see some decreased activity is that prefrontal cortex. And we even know a couple specific sections of the prefrontal cortex. So I'll point some of these out. So lateral just means like on the side. So this is the left side of someone's brain. So lateral prefrontal cortex, prefrontal cortex is right here, like basically right behind your eyes, your orbit bones, those kinds of things. And ventromedial is here in the middle between some ventricles and areas there and gaps and spaces. So hopefully that helps. You see kind of here in this area of the prefrontal cortex, this is where we see a lot of that decreased activity. And some of the major things that we see, because we've been able to get a better sense of what different parts of the prefrontal cortex does, this lateral prefrontal cortex, so over here, this big area, a lot of that is doing cognitive control, helping with working memory. So working memory, depending on if we've done the memory chapter or not yet in this class, working memory is essentially what we call the active engagement and kind of conscious experience of the world that we're working with at any given time. So you can pull in facts that let's say you're taking a test. You're taking a midterm, and you're looking at the question, and you're thinking back to what happened in lecture that day. What was that example that Professor Riches gave? So you're actively thinking that, and you're maybe looking at some of the other questions to see if you've got any context clues, and you're aware of the things around you. Maybe you're at a desk and it's really quiet. There's not much going on around. Those things that are actively in your awareness is your working memory. So you're pulling things up, you're thinking about things, that is working memory. I also like to think of the working memory as that big table, a working bench that the inside out characters are in. So they're calling up long-term memories, they're planning out what to do. That's what you're doing in your working memory. And so that lateral prefrontal cortex does a lot of that, does some inhibition, helps you with your attention. And again, you'll see some of these common things in other areas of the prefrontal cortex because again, the networks in the brain are really big, but it does appear, the more we're investigating, there does appear to be very specific areas that do take on some specific tasks and are pretty common across people. So not that they can't shift and change, but we do see some patterns. So orbitofrontal, so kind of the very front, right behind your eyebrows, basically, is where we're doing things like decision making. We are responding to rewards. We're able to delay gratification. So we're able to say, okay, if I wait till the cookies are baked, they're going to be more yummy, and rather than eating the cookie dough, or at least not eating all the cookie dough. Ventromedial, so can't point to that one. It's in the middle between those hemispheres in the prefrontal cortex. And we're doing a lot of social and emotional processes there. So interacting with people. We're also doing a lot of our regulation of emotions. And it kind of makes sense that would be there. It's a little closer to those emotion centers of the brain. So it's a little more efficient for it to be a little closer to those emotion centers. And so this is a lot of the areas that we see specific depressed activity when someone's suffering from depression. So another thing that we see is the amygdala. The amygdala seems to be overactive in people with depression, and you'll see that kind of common with some of these central kind of middle brain areas with quite a few of these disorders. The amygdala, we see it's overly active in people with depression. So antidepressants do reduce that amygdala activity, and the prefrontal cortex, one of its jobs is to inhibit those emotions. So in someone with depression, it's not doing that quite as well. So the amygdala is sending more signals, maybe more negative signals, negative mood, and then the prefrontal cortex, with its depressed activity, is not inhibiting it as well as maybe it would be, as we might expect with a neurotypical brain. So with depression, we do see some genetic ties here. So genetics play a role in the development of depression, as we've talked with epigenetics as well, diastasis stress. We also see that the environment and stressors play a big role too. So if a family member has depression, any of their family members are about 1.5 to 3 times more likely to get depression. There are genes that are relevant to depression that only activate with stress in your life. So that's some of those epigenetics. You might have this gene, but if you don't have stress, then you will be less likely to get depression, even though you have that gene for it. In addition to these specific brain areas like the amygdala and those areas of the prefrontal cortex, we also see some neurotransmitters involved here too. So people with depression have lower serotonin and norepinephrine. These do each of these neurotransmitters do a ton of things. They don't do just one thing, but one of the things that they do is regulate bodily functions. They're regulating appetite, sex drive, sleep, arousal, mood. You might notice a lot of these things are things that people with depression have challenges with, whether it's sleep, whether it's regulating things, whether it's their sex drive or their arousal level. So these neurotransmitters are part of that puzzle. So you've got these areas with decreased activity, the amygdala with increased activity, but also lower serotonin and lower norepinephrine overall. So all these put together lead to a lot of these different symptoms. So, one of the things that we do for treating depression is medicines. These medicines are really trying to target some of these neurochemicals. So, again, if we go back here, serotonin and norepinephrine are both low. And so SSRIs really focus on serotonin. It's selective serotonin reuptake inhibitor. And so essentially you've got the neurotransmitters in here, then they get reuptaked or vacuumed back up into this neuron to be used again. SSRIs stop that from happening, so there's more serotonin just kind of floating around here, ready to activate, making it easier to activate. So in the prefrontal cortex, for example, that could be really useful because then those neurons that might normally not activate, since there's a little more serotonin floating around in here, they're more likely to activate. You're able to do something like regulate or pay better attention, that kind of thing. MAOIs are monoamine oxidase inhibitors. Essentially, monoamine oxidase, and I might be pronouncing that wrong, I think I have only ever read that, is released by the brain to essentially remove excess norepinephrine, serotonin, and dopamine. So it's kind of a recycler. It takes it as waste and takes it out of that gap. And so that's not super helpful if you have lower serotonin and norepinephrine. So MAOI inhibitors block that process. So you can't have those monoamine oxidases come in and vacuum those up and take them away. So kind of the same thing, tries to keep some, but it works with norepinephrine and serotonin versus SSRIs are only working on that serotonin. And then the last one is tricyclics, and they again block the reuptake of serotonin and norepinephrine. Oh, the MAOIs also are working on dopamine too. So norepinephrine, serotonin, dopamine, tricyclics, serotonin, and norepinephrine. So these can all be really effective and helpful with treating depression. Another big thing are things like cognitive behavioral therapy. But with these medicines specifically, the main idea is that you're trying to have those neurochemicals so it's easier for the neurons to activate. Then for whatever you're doing, you're hopefully making new connections, stronger connections, because you're able to get those neurons to talk to each other a little better. Now, the hard thing here with a lot of these disorders, especially depression, is these medicines only take a couple hours to lead to having more serotonin, more norepinephrine, whatever it is that it's affecting. It only takes a couple hours for there to be more serotonin between those neurons. But a lot of times, for most people, we see that the medicines take a couple weeks to start seeing a positive effect. Now, there might be some different reasons for that, but we're not clear still on how these are specifically affecting depressive symptoms. So it seems like it's a more complicated puzzle than we even realize yet. So part of this is, well, you do have to start making new connections. Once enough new connections are made, you can do things like regulate or pay attention a little better. And maybe that takes up to a couple weeks. But really, in those couple hours, theoretically, we should be able to see a little more improvement in most people, but we don't for a couple weeks. So there's something about this process of how these medicines are working. They do help, they do work. But it's still not super clear exactly how this is happening. One of the biggest thoughts is, yeah, when you get that serotonin there, you're starting to make new connections, stronger connections there. And then once you have enough of those, you can see the outcomes. There are individuals, though, that a small percentage of people who, the same day that they start taking an antidepressant, that they feel some positive effects, which is kind of what we would expect. But it also suggests that people with some of these same symptoms, their brains aren't working exactly the same as another person with those depressive symptoms. So someone who takes that couple weeks for the medicine to kind of kick in to see some outcomes versus a person who is lucky enough to be one of that small percentage to have it working that very day, their brains are probably getting these symptoms that we call depression in slightly different ways, which I think is a really cool thing to investigate, to be interested in, and to understand that brains are very varied. Even with a specific disorder, we can have different brain processes that are leading to those same symptoms. All right, so another one that we use to treat is cognitive behavioral therapy. A big part of this is you probably talked about cognitive behavioral therapy many times, but the main idea here is that we're trying to modify networks of thoughts, change your thoughts, change your behaviors, set new patterns. And really, what we're doing at that level is trying to make the brain work with its plasticity. So capitalize on that plasticity to make new networks, to be able to regulate a little bit better, to be able to regulate a little sooner, to do things that you find enjoyable. So that's more common in your brain. So this is really the things that cognitive behavioral therapy is doing. And this is kind of the phases of going through cognitive behavioral therapy. Again, just a reminder for it, pause the video, look at those. I think that was also in your book, but we won't dive into it in a lot of depth. Another thing that works really well is exercise. Exercise is really great for reducing depressive symptoms. And essentially what we've seen, we've tested medicines on its own, we've tested therapy on its own, we've tested exercise on its own, and each of them are good at reducing depressive symptoms. But anytime we put them together, we see better outcomes. So if you put exercise and medicine together, or exercise and therapy together, or therapy and medicine together, or all three together, you get a bigger boost by putting all three of those together on average. Again, there's going to be some people who doesn't work, who all three of those doesn't work for, but basically on average, any combination of therapy, medicine, exercise works better than any of those alone. And those are kind of the three biggest, best ways. Another positive of exercise is that it helps with the rest of your body as well. And again, your whole body is a system. So your brain is tied in to the rest of your body, the hormones, the muscles, the blood flow. So as those things are working a little bit more optimally, it does help your brain work a little more optimally as well. So exercise, therapy, medicine, all really good things for depression. Other treatments that we use are brain stimulation. So essentially all the types of brain stimulation have been tried for depression. And let's watch this little video for electroconvulsive therapy. In old horror movies and also stories of actual things happening in asylums back in the history of our field, electroconvulsive therapy was very damaging and really harmed people. In some cases, was even used as a punishment for people who were just not behaving well, and they were hard to take care of, which is really, really awful. But we still do use electroconvulsive therapy. This is where you put electrodes on a person's scalp and you induce a seizure. It is one of the higher risk options here because you do have to be under general anesthesia, and general anesthesia in and of itself is a pretty high risk process. Deep brain stimulation is kind of similar, but you're actually putting surgically electrodes into the limbic system to try and activate specific neurons. And so again, that one's also you're needing to be under anesthesia for that, and you are having surgical procedures on your skull, so very high risk. So repetitive transcranial magnetic stimulation is a lot lower risk. So it's not an invasive. You've got essentially, you could think of it as a backwards MRI. You've got a little machine that goes around your head and uses magnetic stimulation to try and depolarize neurons in your prefrontal cortex, especially for depression. That's where we're kind of aiming at. So you kind of mess up the activity of the neurons here in your prefrontal cortex, and then as well with therapy, with medicine, things like that, it helps them build new connections. So we'll watch this video in a second, but the main idea between any of these is that you are disrupting the patterns that those neurons are taking. So you've got an active amygdala and your prefrontal cortex is not regulating it well enough. So with that, you can use repetitive transcranial magnetic stimulation. You can interrupt that network. So the common pattern, the brain's really good at making those patterns, making them really efficient. So it's running through that pattern of rumination, depression, terrible feelings, not feeling like you're going to want to do anything. And that transcranial magnetic stimulation interrupts that. So the neurons are like doing weird things. They're not really in their pattern. So now you can give them a new pattern. That's basically the idea with all of these deep brain stimulations, kind of intentionally trying to stimulate the areas around mood. But essentially, it's trying to use your own patterns of plasticity to help you to have your brain work a little bit different way. So let's watch this video of what electroconvulsive therapy actually looks like.
Electroconvulsive therapy, or ECT, is often called a treatment of last resort for patients who haven't had success with drug therapies, who have life-threatening psychiatric conditions, or who are suffering a catatonic state. ECT induces a brief seizure in a patient which resets the brain functions associated with some psychiatric disorders.
It's typically indicated for treatment-resistant psychiatric conditions, most commonly mood disorders or depression, but there are multiple types of depression, so it can also be used to treat bipolar depression.
The majority of ECT treatments are managed like outpatient procedures, and the patient is given general anesthesia.
When the patient's asleep, the stimulus is delivered, the seizure is monitored, they'll have just one seizure.
An electrical current is given to the brain, low enough not to harm the patient, but high enough to trigger a seizure. The treatment team can even touch the patient.
The thing that concerns patients the most is that they know that they will be having a seizure. They're concerned about what may be happening while they're either asleep or while they're having that seizure. And thanks to the anesthetic, it's very hard to tell. In fact, only way you can truly tell if they're having a seizure or not is to kind of monitor the motor activity and then monitor the EEG activity.
The patient awakens soon after and is monitored for a short while like any patient who has undergone general anesthesia. Within a half hour, they'll be discharged. In some cases, a handful of ECT treatments may be all that's needed to make medication therapy work. For other patients, regular recurring ECT treatments may be needed. In Morgantown for the WVU Health Report, I'm Dr. Raleigh Sullivan.
Good example there of what ECT really looks like. Again, with deep brain stimulation, you're getting electrodes implanted into the skull, so that one's going to be as involved. Transcranial magnetic stimulation is a lot less involved, a lot less invasive. You go in, you get your neurons magnetized, and so essentially with all of these you're trying to make the neurons active and do a different thing than they're used to doing to allow you to make new connections and help with plasticity. So this is definitely going to be better if you're using it with skills and techniques that you're learning from therapists, and like they mentioned there, medication might start working after this point. So these are some of the kind of last resorts if the other ones don't work. If I remember correctly, current practice is that you have to have tried at least 2 categories of depression medications. So you've tried like MAOI inhibitors and SSRIs, and if they're not working, then you might be a candidate for electroconvulsive therapy. All right, so there's a lot of detail there on depression, and specifically some of the ways that it's related to the brain, to the neurotransmitters, to genetics. And with this is an area of the brain that we know a lot about. And disorder that we know a lot about because it impacts so many different people. Some of the other disorders that we'll cover have some similarities in like their specific brain areas or their specific neurotransmitters or their specific genetics, but some of them we have only a couple bits and pieces of that. So jumping now to bipolar disorder, each of these we kind of go into a little bit less detail through the rest of the chapter, but hopefully that gives you a good sense of what we're looking at when we're looking at the brain and the neurobiology of these different disorders. So we already talked about the symptoms of bipolar disorder and how it's distinct from depression. The interesting thing here is that we don't really understand the neural circuits of bipolar disorder that well. So you might have seen in the book some of the specific things that we do know and how it is distinct. But with this, it does appear that there are just still things that we need to discover about the neural circuitry of bipolar disorder, or perhaps because there is such variance. Maybe as we get better measurement techniques and tools and ways to pinpoint where things are happening, maybe there are a couple specific different kinds of things that to us look like what we call bipolar disorder. So maybe there's actually two different types of disorders or more than that that lead to these types of symptoms. So it's really not understood well. We do see that there is high genetic contribution. So we see that the emotion processing centers in the brain are different from someone who's neurotypical. We also see some similarity to some schizophrenia genes and brain profiles. So people with schizophrenia, they have a couple of those areas of the brain that we see some differences in. We also see some genes that are related to schizophrenia or correlated to developing schizophrenia. We see some of those as well with bipolar disorder. So the book suggests, and some researchers suggest, that maybe bipolar disorder would be better categorized as something like schizophrenia. And that kind of gets into a whole thing of there's a lot of different variation in schizophrenia as well. Maybe what we're calling these disorders are actually multiple similar things that are distinct. So as we go into the future with more research, hopefully we'll have a better, clearer picture of them so we can better treat these things. So a big thing is that it does seem that people with bipolar disorder are hypersensitive to rewards as well. So with this, people have varied patterns of manic and depressive phases. This can make it very tough to investigate because someone might be in a manic phase but coming off on the tail end versus someone's in the middle of it versus someone's just starting it, and there might be different brain processes working there, but it's a really hard thing to get samples and like investigate at that specific time. So that's really difficult. As well as with depressive phases, while the most common experience with bipolar disorder is longer spans of depression, just because that's the case, it doesn't mean that you're in the same type of phase of depression. Maybe you've just started, you're in the middle, you're at the end. And so getting good samples of people with bipolar disorder, usually you're asking for volunteers or collecting volunteers who will be part of your study. And each of them are going to be at different phases of their manic or depressive phases. So one thing that we do see across the board is that environmental stress can trigger depressive phases in bipolar disorder, as well as positive life events can even trigger manic phases of bipolar disorder. So having those increases of stress can lead to depressive episode. Having those positive life events, accomplishing a goal can lead to a manic phase. So these are things to definitely be aware of and watch out for. It does appear that depression phase seems really linked to low norepinephrine and serotonin. So that's really similar to what we just talked about with major depressive disorder. So with that, you might say, oh, well, great. Well, we can just use some of the same treatments for bipolar disorder as depression because usually they're suffering from depression. And that's kind of one of the schools of thought. But a problem with that is that the manic phase is linked to low serotonin but high norepinephrine. So if you're using something that brings that norepinephrine up too much, you might accidentally trigger a manic phase, which makes that very difficult to figure out exactly how to treat this. So the treatment, we usually do use some standard depression medications, but they do have that tendency to trigger manic episodes. A challenge here is sometimes you might think that you have someone who's suffering from depression because their checking all those boxes to diagnose them with depression, but actually they have bipolar disorder, and so you give them that medicine, all of a sudden they're in a manic phase, and now you realize, oh no, they were actually bipolar. Now they are at risk because of that as well. So oftentimes mood stabilizers are used. Lithium and Depakote are two examples of that. Both of these are trying to increase GABA, which is an inhibitory neurotransmitter. It helps other neurons say, like, calm down, don't do as much activation. So both of them do that. But lithium, as well as that, also decreases dopamine and glutamate. And those are excitatory neurotransmitters, so telling next neurons in the path to do a thing, activate. So increasing GABA does seem to help. So with that, you also have some people very often to an individual level testing to see, hey, if you're in a depressive phase, can we give you this specific standard depression medication? Will it help you? With very careful watching to make sure it doesn't trigger a manic episode. All right, so again, we don't know a ton about bipolar disorder. There's those specific neural circuits that seem similar to some things that we see in schizophrenia, some gene profiles, and we see a couple neurotransmitters that are related here. We see the low norepinephrine and low serotonin for depressive episodes, but low serotonin and high norepinephrine for manic episodes. So there's a lot more to learn about this one as well. So anxiety is another one that we'll talk about here. So anxiety disorders include excessive and persistent fear and anxiety, and also related disturbances in a person's behavior. So here we're talking about things like, and this isn't an exhaustive list, we're talking about generalized anxiety disorder, panic disorders, specific phobias, and social anxiety disorder. So those are some of the disorders in that anxiety disorder spectrum. And we see that anxiety in general, about 25 to 30% of the US population will be diagnosed with an anxiety disorder across their lifetime. It is genetically linked. There are some genes associated with developing this, but it does appear to be less heritable than schizophrenia or bipolar disorder, which are a lot higher heritability. But it still is part of that diathesis stress model as well. So the neural mechanisms, we see two specific areas of the brain. One is the amygdala. So the amygdala is one of those things that activates to threats, activates for things like emotions. And so it seems that in people with anxiety, the amygdala is hyperactive. It's sending signals, it's sending potential threats very easily. So it's very easy to send that this is a bigger threat or that this is a threat, even if it wouldn't be something that someone with a neurotypical brain might not say that is happening. Or we would say, we haven't, depending on where you are in the class, we might not have covered the neurotypical versus neurodivergent concept yet. So basics of that, on average, we expect brains to kind of do these sorts of things. That's the average. That's kind of what we call neurotypical. Basically, on average, we see brains do this. Neurodivergent or neurodiverse is things that are outside of that. So the example of an amygdala sending more or stronger signals is not typical, doesn't fall within the average. That's more activation than we're expecting, so that's divergent. So that's what we're talking about with that. So essentially, this can trigger panic responses through the central nucleus, and this controls body functions like heart rate. This might be due to less GABA in this area. So we see some of that neurotransmitter involved here. And again, that's an inhibitory neurotransmitter that helps things calm down or stop activating or regulate them activating. But that's the bottom-up process. So we get some sort of input, or the amygdala thinks there's an input and sending a signal that there is some threat or some potential threat. So that's the bottom-up process, but also there are top-down processes as well. So the top-down control is coming from the prefrontal cortex. So this is similar to depression we were talking about, helping regulate some of those emotions. We see reduced activity in the prefrontal cortex in people with anxiety. So in general, that area of the prefrontal cortex, you can regulate some of your emotions, but if you have reduced activity in the prefrontal cortex, it's going to be harder to regulate those emotions. It's going to be harder to say, oh, this isn't actually a threat. Your brain is telling you this is a threat. You've got reduced activity. It's less capable or less easy to do, regulate that and say, nope, this isn't, like tap that back down for someone with anxiety. So with that, we do see some of those neurotransmitters like GABA involved in that process, but we see the amygdala and prefrontal cortex kind of talking with each other, and the amygdala is doing too much and prefrontal cortex is doing a little less than we would expect on average. So some medicines that we use are targeting GABA. So benzodiazepines, things like Valium, Xanax, Ativan are used short term. And essentially, they pretend to be GABA, and they inhibit neuron firing. They pretend to be that neurotransmitter and inhibit some activation. We also see SSRI and SNRIs, and that N stands for noradrenaline. So that's selective noradrenaline reuptake inhibitor. So similar to SSRIs, keeps it there inside the synaptic cleft so that it's easier to use that. So with that, benzodiazepine only work for short times. So they have additional side effects. The body adjusts easily to them. So the recommendation is to only use them for a couple weeks, it's like 2 to 4 weeks. So mostly antidepressants are one of the primary things used now for treatment of anxiety. And they can be very helpful. Other things that are really helpful are cognitive behavioral therapy. So again, we're talking about the amygdala as being overactive, the prefrontal cortex as being less active. So we can use the plasticity of our brain in combination with these medicines to help a person be able to practice that regulation, to practice regulating those senses of threats that are very real. Their brain is giving them the brain giving the input and the input actually being there is the same thing, right? So the cognitive behavioral therapy has been shown to reduce amygdala hyperactivation. And essentially, you're building new neural circuits. You are practicing with regulating those emotions, practicing your understanding of what you're perceiving as threats, and being able to reduce the amygdala's action and help your prefrontal cortex do that regulation ability as well. And combining that with medicine is often helpful for a lot of different people. So hopefully you're seeing some common patterns across these different disorders, that there's specific brain areas, that the combinations of things like medicine, like therapy, like surgeries are all really aimed at helping the brain kind of work more as we would expect, so that the amygdala and the prefrontal cortex are working in balance or in harmony with each other, rather than the amygdala is doing too much and the prefrontal cortex is not doing enough. So obsessive compulsive disorder is another classification of disorder, and these are thoughts and urges that are intrusive. That's what obsessions are. And then the compulsions is needing to engage in repetitive behaviors or mental acts. So this can be actual physical behaviors, or it can be like repetitive statements to himself, or even in your mind. And these to be classified as OCD. So again, this is another example of someone might say, oh, that person's really clean. They're very OCD. Again, that's a really terrible thing to say. It's not a good joke. Please don't do that. It's very time consuming. It really is debilitating to a person's life because they're taking more than an hour a day on these obsessions, on these compulsions, and essentially the urge to do it is something that they cannot get around. It only decreases that stress and anxiety and that urge when they do those things. And they know that it doesn't make sense. So obsessions, I've got some examples here. You've got those persistent, unintentional, and unwanted thoughts. So these are highly intrusive. They're unpleasant. They're things that the person doesn't want. They would like them to be just gone. And a couple examples of obsessions. You might be consistently thinking, oh, did I lock the car? You're getting to sleep. Oh, did I lock the car? You're doing something else, even though after you've literally just locked the car. Oh, did I lock the car? Maybe something happened. Maybe I accidentally pushed the button. And these are unintentional, unwanted thoughts, and they're intrusive, and they're taking up your mental energy, essentially. They're taking up so much time of your day and your cognitive effort to try and ignore them or get around them that it really impacts like your work, your relationships with people. Another example would be you see a bunch of movies and your obsession might be that you have to have those alphabetical. They're not alphabetical. It's really intrusive. It's really unpleasant. So we've got a cycle here. You've got your obsessions, which you have those unwanted urges. It leads you to that feeling of that this isn't how it should be. Then you oftentimes have a compulsion maybe associated with it or something that you do to get rid of that. And then now you've got some relief until it comes back. And so it is If you know anything about behaviorism, if you can remember back to them, essentially that relief is a reinforcement. So it gets rid of that obsession for a little bit of time and you feel a little bit better. That reinforces this. The brain is really good at spiraling into this kind of obsessive compulsive disorder spiral. So compulsions, a couple examples here. Oftentimes these are repetitive or ritualistic acts. They're aimed to reduce that kind of distress caused by the obsessions or a feared event. So continuously locking the car would be an example. If that is an obsession, oh, did I lock the car? You might be clicking your button to lock your car very often, or going to the window to make sure you can see the car's lights lock, or actually having to go physically out to do that. That would be an example of a compulsion. Washing hands is one that we see pretty commonly in media. Organizing is one we see pretty common. But again, these are things that are taking a lot of time in a person's day. So a person seeing, oh, my desk is pretty dirty. I kind of want to clean that. That's not the same as obsessive compulsive disorder and this cycle of needing to do these things to relieve that anxiety. All right, so what is going on in the brain? We do see that there are some genetic components. So when we look at someone with obsessive compulsive disorder, if they're an identical twin, about 57% of the time their identical twin also has the disorder. So it's not entirely genetic, but it is pretty, there are some genetic ties. It is a little less than genetically tied than some of the things that we've discussed, like schizophrenia or bipolar disorder. And with that, we see the orbitofrontal cortex, which we've mentioned in a few of these here in the prefrontal cortex, is hyperactive in people with OCD, and it's very easily triggered. We also see that the dorsolateral prefrontal cortex, so here we see some of those areas, and then lateral, you can remember, is on a side, and the left superior temporal gyrus are part of the circuitry for OCD. So one of the big ones that we see is the orbitofrontal cortex, and it seems to be hyperactive, really easy to trigger, and again, it's not acting as we might expect it to. So cognitive behavioral therapy can be very helpful. So exposure and response prevention. This is very similar to extinction, which we'll talk about in some of the things later. Essentially, using extinction on an obsession, exposing in a safe environment with a therapist to something that might make you have those feelings or those urges, those anxieties, those obsessions, those compulsions, and working through that slowly at a time. SSRIs can also be very helpful. Transcranial magnetic stimulation and deep brain stimulation have also been used as well. So transcranial magnetic stimulation, again, that is the one where you've got the machine that isn't as invasive. Deep brain stimulation, you've also actually got the electrodes in the brain for that. So, but again, the idea with these is that you're trying to use plasticity so that that cycle that the brain has gotten really good at doing of that obsessive compulsive disorder cycle is broken up. So you can now do something different. You don't have to go step 1, 2, 3, 4. You can go step 1 maybe at the end of your therapy, you get that step 1, you recognize and you do something different. But that takes a lot of effort. It takes a lot of work. It takes some of the help from these kinds of treatments as well. So let's see an example of a person who has obsessive compulsive disorder. They talk about how it impacts their life as well as they go through to do, if I remember right, I think they're doing deep brain stimulation. So good example of modern psychosurgery. Yeah, and it's deep brain stimulation for this person.
Tonight's Health Watch, encouraging news for people struggling with obsessive compulsive disorder, or OCD.
Yeah, it's not drugs or talk therapy here. This is brain surgery. CBS 2's Dr. Max Gomez explains why this may be the best option for some. Dr. Max?
Yeah, that's right, Christine. You know, we've all seen some funny depictions of OCD. People who have to repeat certain routines like washing their hands or checking that the front door is locked over and over and over again. But severe OCD is no laughing matter. It's a disabling mental disorder. Randy Hurt has severe obsessive-compulsive disorder. It became so bad he couldn't keep a job.
I needed to take a shower, and I needed to do certain things. I needed to eat breakfast or whatever, regardless of how much time I had. I think it was 17 jobs in 4 years.
The obsession is something that is the person knows is unusual and silly, but the person can't control it, and the thought itself causes marked distress.
The customary medication and talk therapy didn't work for Randy. Then his mother came across a possibility of surgery. It's called deep brain stimulation. Thin wire electrodes are inserted into tiny brain areas to disrupt nerve pathways that involve action, motivation, and reward processing. Small electrical currents disrupt the amount of reward a person assigns to their repetitive, compulsive actions.
Patients are kind of fully awake at this stage, and we have a kind of a rating scale device where they rate how severe their OCD symptoms are at that time.
Over the next several weeks and months, the electrical settings are adjusted. Since his surgery 4 months ago, Randy can work on his car and mow the lawn, which he couldn't do before. But
I would like to work again. At some point, I would like to get back to work.
I think we're just beginning to figure out the types of patients that we can help. And so I think there are quite a number of people that in the future are going to be helped by deep brain stimulation.
now, even though deep brain stimulation has been done thousands of times for Parkinson's, epilepsy, and even depression, no one is advocating it for anyone but the most severe cases of OCD that have failed all other treatments. The procedure is FDA approved, and it's usually covered by insurance as long as you go through all the other treatments first.
Last resort.
Last resort.
Thank you, Dr. Max.
I like that short video. I think that that news team does a good job with their edit there of really showing this person's distress and how distressing obsessive compulsive disorder can be. This is not one thing my kids sometimes do. It's like, oh, it's time to get out of the house. We're going to be late. It's like, oh no, I didn't brush my teeth. I forgot that. I have to do that before. It's not that. It is very distressing, very ingrained. This cycle is. Neurons are very good at building patterns and having those networks very strong. And that's essentially what's happened here, is that because of these different brain areas, because neurons are really good at building neural networks that can activate really easily and trigger, because it's being used so much, this compulsion is triggered very easily. These obsessions and these compulsions need to be done to receive that relief, and then that reinforces it, which is very unfortunate, makes it very hard, like that person, to hold jobs, to do things. And that is why, in many cases, doing something like this type of surgery might be a resort that you would take when it's not responding to other treatments. Again, though, cognitive behavioral therapy, being able to work through it without any kind of intervention in your brain, you're still intervening in the brain. You are still using the plasticity of your brain to make new pathways. Next one that we will talk about is post-traumatic stress disorder. So post-traumatic stress disorder is classified as a trauma and stressor-related disorder in the DSM-5. So it used to be under the category of anxiety disorders, but it was realized that, oh, there's a lot of other similar disorders that are stressor-related and trauma disorders. So it's in that category now. So with this, the criteria for PTSD specifically needs to be exposed to actual or threatened death, serious injury, or sexual violence. So there are other trauma-related disorders that wouldn't quite reach that criteria, but we're going to focus here in this class on PTSD, so that exposed to actual or threatened death, serious injury, or sexual violence. So with this, the symptoms have to last for at least 1 month. You see a lot of intrusive memories and flashbacks, avoidance of trauma-related stimuli, things that might trigger those memories and trigger some of those anxieties and feelings. Persistent negative emotions, so this can be anything from guilt, fear, anger, shame, detachment, irritability, as well as exaggerated startle response, so being more jumpy. So we see some brain areas associated with a lot of these types of symptoms. So we see the amygdala, the hippocampus, and norepinephrine all playing a part in this process. Essentially, what we see is that the hippocampus increases norepinephrine and sends signals through the amygdala when it detects threats. So if you remember, hippocampus is involved in memory, And usually, when it's using and directing memory creation, memory recall, you working during working memory, we see that it will use a bunch of areas of the brain. We see that in someone with PTSD. Essentially, the hippocampus is sending its signals through the amygdala, so that emotion center of the brain, rather than throughout the brain in general. So it's got a lot more direct connections straight to the amygdala versus in someone with a without post-traumatic stress, that working memory and that hippocampus would be sending signals kind of wider around. So the hippocampus, another thing that we see is that it is smaller in patients with PTSD. And so this is probably because of it's not being used to network around with the whole rest of the brain. So it's probably got decreased dendrite density. And this is a hard thing with humans. We've talked about neurogenesis in humans before. The hippocampus is one place neurogenesis happens, so there might be less neurogenesis happening in someone with PTSD, but again, that's a hard thing to tell for sure in human examples. It is an easier thing that we can definitely see in examples with rats, but doesn't, there's more neurogenesis happening in rats than in humans. So that might be the case, but definitely there's a case of less connections to other areas of the brain. And so we see that we can actually see the mass of the hippocampus shrink because of the less dendrite and axon branches. So it's not as connected. A good thing that we see is that after successful cognitive behavioral therapy treatment, also during successful cognitive behavioral therapy treatment, we see that it gets denser, it gets bigger, the hippocampus grows again. So this is not like a neurodegenerative illness that we've talked about in other chapters. We can see the development of new connections as people are getting treatment with PTSD. So with that norepinephrine, essentially you have the amygdala, or sorry, you have the hippocampus talking more directly with the amygdala, whereas it might in a person without PTSD talk around the whole rest of the brain, but it's sending through the amygdala, which is really related to things like emotions and fear responses and trauma responses. So a little bit different set of signals and set of patterns that a PTSD brain is doing than someone without PTSD. So, treatments, cognitive behavioral therapy style therapy works really well. So there's a variety of different types of therapies that can work that fall under the cognitive behavior, the CBT spectrum. It's kind of a big umbrella, and there's other like specifics underneath it. But again, that's not the focus of this class. This class is focused on the neurobiology. But the basics here is identify negative thoughts and even replace them with positive or more adaptive thoughts, things that you know that you can change or ways to move around those, essentially making new networks, helping the brain make networks with your working memory with intentionality to make new networks in your brain. Another thing that can be very helpful is exposure therapy. So this is not something to be done on a person's own. This is something to do with a trained therapist. So this example that I'll show some bits and pieces of, the whole video is pretty good, but this is a person with a phobia, so a little bit different, but it does have a good example of incorporating cognitive behavioral therapy and exposure therapy put together to give an idea of what you might do. So we'll watch that in just a second. And the last is eye movement desensitization and reprocessing, and this is again, one of those kind of subcategories that kind of falls under the umbrella of cognitive behavioral therapy. And it's not really clear theoretically why this works. Essentially, you're tracking someone's moving finger or moving object with your eyes, or paying attention to like taps on your body, or intentionally tapping on your own, listening to sounds, kind of focusing on something as you might be talking about something different, maybe talking about something directly connected to the trauma. But essentially, it looks like what you're doing is you're using your working memory to focus on things, using your brain a little bit differently than it's used to. So you're kind of in a new situation, kind of like trying to focus on something to enable you to build more plasticity connected to and around those trauma responses. But let's take a look at this exposure therapy. Again, this is an example of something that you would do with trained therapists. Don't try to exposure therapy yourself. You will probably end up with additional challenge and trauma if you tried to do that. And we'll kind of skip through a lot of this video. The intention here was for a specific phobia and how you would use exposure therapy in this specific style is in one day, in a course of, I think it was like 4 or 6 hours, to do exposure therapy just consistently over one day and get rid of a specific phobia of snakes. But the ideas behind it are pretty easy to pull out and see how it would be related to the trauma that you might have PTSD from.
Meet 22-year-old Mariam Doom from Venezuela, clinical psychologist Lars Göran Erst from Sweden, and Alf. He's an American corn snake. This multinational threesome is working together. Mariam helps out when Alf gets tangled in Erst's belt loops, and Erst helps Mariam put Alf around her neck. The picture looks simple enough, unless you go back in time, just 3 hours ago, as Mariam was preparing to meet Alf for the first time. Mariam has a specific phobia, a fear of snakes. Other specific.
All right, I'm going to jump around to a couple different places in this. And I want to show essentially what they do first is they sit down and they talk about what will happen. Like, obviously they've already signed consent forms, they know what will happen, but this is the day of the treatment. And so they're talking about what is going to happen, what am I going to do, what are you going to do, how should we go about this process, working on it together.
You suddenly pick out the animal and throw it in the lap of the patient. That will never happen.
It's teamwork. Erst interviews Mariam for 45 minutes and then describes and prepares her for treatment in an additional 15 minutes.
So I will challenge you to try things, but I will never force you to do anything that you're not.
It's critical to determine Mariam's worst fear, what's called her catastrophic belief. Her catastrophic belief is that if a snake is loose and she can't escape, she'll have heart failure.
How certain are you then that you might die as a consequence of that interaction?
Maybe 70%.
70%, okay.
So this is a good example of that cognitive piece of cognitive behavioral therapy, talking about things, planning things out, working through things this way. And then during the course of the interaction, the actual exposure to the snake, they're also doing discussions of the negative thoughts, replacing it with positive thoughts. So let's see when they first come in. Let's see if I can find that. They're probably about 3 meters away, so like 12 feet or something away, across the room from one another. And this is kind of their first interaction here with the snake.
Standing here now with my back towards you.
Erst does that for 2 minutes. What is Mariam thinking?
It was horrible. I felt that I was going to leave the room and that it was, stronger than me.
And what was Erst thinking about her reaction?
Maybe not the strongest I've seen, but up there among the 25% strongest.
So this example here is a specific phobia. So definitely different than post-traumatic stress, but similar kinds of things. There's different things that would trigger the kind of responses in post-traumatic stress. And this is an example of that exposure therapy, trying to expose yourself to those kinds of triggers, work through them at the same time, see that they're maybe not as catastrophic or there's things that you can do about it to replace or adapt in that kind of situation. So let's see what's happening a little bit further forward.
With your stomach.
She calms down.
So, what about the name for it? And where are you going?
I'm going to move here.
Okay. What do you think it feels like?
This is it's a nice snake.
Her anxiety is down.
30, great. You're sitting about, what is this, 3 meters away?
Yeah. She decides to approach.
Okay, I'm going to approach you.
Yeah, good.
But hold it.
Yeah.
What psychological principles might...
So this is a good example of that process of being exposed to something. So while that is specifically about a phobia, the same kind of thing could be done with a variety of things with post-traumatic stress. So helping work around those thoughts, make new patterns, make new networks, make new choices about behaviors to do when there's triggering events around whatever it is that you have triggers for. So, and also that I think it's a good example to show them working together as a team. Like they mentioned near the beginning of the video, they're not just going to throw you in there with a snake, like Raiders of the Lost Ark and dropping down into that tomb with all the snakes. You're going to work step by step to that. Other ways that you can use exposure therapy, VR is used a lot now, watching or reading things so that it's even another step divided. Like you're not actually there in the room with the thing. You can be in a VR headset. So you know that you're actually sitting in a chair in an office, you're totally safe. And that can be used for both specific phobias and PTSD. So there's a wide variety of ways to expose. And the intention is like little bits at a time as you work through some of these skills to get to that point. Again, you're working on plasticity. So for post-traumatic stress disorder, there are different medicines that are used as well. We see SSRIs, MAOIs, tricyclic antidepressants as well, mainly because we see norepinephrine plays a role here, but it seems there's other neurotransmitters too. And so we kind of try as much as we can with the neurotransmitters that we know how to affect. SSRIs have fewer side effects, so they might help specific people. Another thing that's been tried recently are psychedelic drugs. So MDMA or ecstasy, psilocybin, ketamine. These have good evidence of use with cognitive behavioral therapy for post-traumatic stress. Essentially what you're doing there is similar in some ways as something like the ECT, the electroconvulsive therapy. You're having the neurons work a different way than they usually work. So sending out more different signals across the brain. And with that, with cognitive behavioral therapy, something like exposure therapy, you can start making new networks. So hopefully you can see with these different treatments, whether you're doing cognitive behavioral therapy, whether you are doing a medicine, whether you are literally planting an electrode into someone's brain in an area to help treat with depression, you're really working at the neural level to make new connections, to help neurons talk to each other a little bit more as they should be. So you're trying to bring that brain into communicating as you might expect it to, so you don't have these kinds of symptoms. So it is all about plasticity. This is why this is a chapter that we get to after we've talked about like neuron structure and function, brain areas. But hopefully you've made a lot of good connections today with memory. You probably know a lot about memory already before we even get to a memory chapter, or depending on the class term, you might have already covered memory. But same thing, you're making connections. So the treatments for these different disorders, while there might be specific areas of the brain, specific medicines that work better for the neurotransmitters that are affected, the main idea behind it is plasticity of the brain. So as a reminder, double check your schedule in the syllabus to know what the next chapters we are going to be reading are, so that you are reading the correct things. There might be reading material in Canvas, this type of thing. So just double check your schedule, double check the Canvas for readings, to that kind of thing.